Thanks all so much for joining the webinar today. This was something that we've pulled together fairly quickly given the concerns that we have around synthetic opioids into the drug supply in Scotland. So I'm Kirsten Horsburgh, Chief Exec of Scottish Drugs Forum, and really thankful to our speakers that have joined us today as well, from Dublin, and to give a European perspective and for the Scottish perspective as well. So I'm not going to say too much at the start. We've got a very tight timescale in terms of just being here for an hour, and we've got 4 presentations for you to hear from today. We did put out an alert around nitazenes and synthetic opioids last week, which we will post in the chat so that you have access to those resources as well. And please do feel free to post questions in the Q&A box throughout the webinar. And we will, at the end of the 4 presentations, we will get through as many of the questions as we can. And our speakers are also available to respond to those questions that you pop in the chat as well. So without further ado, I will just invite our first speaker, who is Nicki Killeen from the Health Service Executive in Dublin. And Nicki, over to you. Thank you.
Thank you so much, Kirsten. I'm delighted to be here today to talk to you all about our response. I am Nicki. I work in the Irish Health Service Executive, which is essentially the public health service of Ireland. I am a project manager there on emerging drug trends. And what that means is I work with a number of different stakeholders to see how we can monitor and respond to drug trends in Ireland. So today we'll be looking at the timeline of events from the HSE's perspective, some of the work that we're doing and next steps. And just to say, I work in partnership with Professor Eamon Keenan, who's the National Clinical Lead, who I would have coordinated the response to nitazenes with. Just to give a tiny little bit of context in terms of the Irish landscape, and we do have many similarities to Scotland. We do have a long and well-established heroin use prevalence in Ireland. So we've an estimated over 19,800 opiate users, and we would have had very similar patterns to Scotland in terms of our first wave of heroin use in the 80s, early 90s and early 2000s. And most of our services have predominantly been developed in response to opiates. So we have addiction and homeless services where we know we can reach these people, but we've long established services. Similar to other trends in Scotland and I suppose the rest of Europe, we've seen an increase in prevalence and increased availability of cocaine, which has completely changed our crack market, with crack moving from an open to very open market with lower costs. And we're also monitoring the changing tablet market, which is something that we're also monitoring in Scotland in terms of new benzodiazepines. Now, we haven't seen the same impact as the nitazenes, but we are looking at new substances such as bromazolam. We do have a greater diversity of populations. So in terms of our responses, we're looking at festival settings, drug checking. At the moment, we've back a pace in festival settings only. In terms of our naloxone, we've an established national program. It's prescription, available for peers and families, and we currently have a new peer program being rolled out. We have a safer injecting facility, which is pending opening. So that's just a very quick concept contextualization of the Irish landscape. We do tend to look very closely at the rest of Europe in terms of what drug checking services are saying, and we do closely look at the radar Scottish early warning system, and we have been keeping an eye on what's occurring throughout Scotland, throughout the UK and throughout Northern Ireland for the past few months. So we were aware of the possibility, and we were beginning to prepare for the possible emergence of nitazenes, which are relatively new to the European drug market. And I know Lynn will chat a little bit later about some of the occurrences there. Just a very quick oversight. They are substances that were developed some time ago in the 1950s. While we do say new, we mean that they're new to the Irish market. So we're calling them new psychoactive substances for that reason. They have presented in powders, tablets and liquids. And we're particularly concerned about the emergence in tablets and falsified medications such as oxycodone and benzodiazepines in the UK, and that is something we're monitoring. There's a variety of the different compounds that have been noted in the UK and the rest of Europe. In Ireland, so far, we've only seen one on the heroin market, which I'll chat through my slides. So in terms of our timeline and the events that occurred, I'm going to look at 2 clusters that we've had. So our first cluster was on the Dublin heroin market from the 9th to the 14th of November. And the second is more recently in Cork, which is a southern region, and I suppose our second capital. So in terms of the 9th of November, we were made aware from a very early phone call that overdoses were occurring. These overdoses were concerning. They were not typical overdoses. They were requiring additional amounts of naloxone. So first responders very quickly identified something different is happening here. So this triggered a very urgent review from ourselves with NGOs, service providers, Gardaí, which are our local police, our law enforcement, hospitals, our two main hospitals in the city, and our labs. So we essentially worked tirelessly that morning. There was significant communication, trying to review what was coming in as anecdotal feedback at the start. So very early on, the numbers jumped in the city. So what we noted was it appeared that people had bought their substances across one strip of the city centre, and sporadically overdoses were occurring, but it was contained to the city centre. We were monitoring the anecdotal feedback, but we decided at that point to use emergency call-outs from the ambulance and fire brigades as our surveillance tool, I suppose. So that was going to be our main piece of information that we got an account from twice daily, so in the morning and in the evening. So very quickly we identified throughout the 9th there was 24 overdoses for that end of day. And anecdotal feedback was coming in that there's a new powder. Overdoses are very quick. There's no high. People are just falling straight into overdose. And throughout that day we were obtaining paraphernalia, syringes, biological samples and drugs themselves. And all we were finding was heroin. So there was no substances of concern on the 9th, but something was happening. So it was really important for us at that point in time to issue our first alert. We went to the media, we went to services, and we said, there's overdose clusters, something's happening. We can't name what it is yet, but we need those wraparound supports, which is what Tony will speak to in a little bit. So further throughout the 10th, we continued our work. We were reviewing samples. It was heroin. There was nothing concerning. The same coming from the overdose cases we weren't able to identify. So very late on the 10th of November, the Forensic Science Ireland lab confirmed traces of nitazene substance. So we were able to go out very late. It was about 9 o'clock in the evening with our red alert, and we issued that for Dublin. So we escalated that risk level at the highest threat that I think that we could put out from the health service executive. And what we did was we put it on road traffic signs, because at that point in time, so late in the evening, how do you reach people? So it was getting to the services that were open. And then for that weekend, it was working with the Liffey, and I know Tony will speak to that later, in terms of the outreach support. It was important for us, lots of lessons learned. What do you do on a Friday night if this kicks off? Where do you get printers? How do you get the resources? So we went out on the Saturday with the Liffey, who were doing face-to-face work as a trusted face, I suppose, with the people who use drugs, and we knocked into the homeless services and put posters around the city. So these are just some of the pieces here. I won't go into them in too much detail because I know we were limited for time, but just in terms of our risk communication, it was really important for us to put out that we'd found nitazenes. This is very concerning. We were also conscious that at this point in time, we did not know a lot. So we were thinking they could appear in powders, they could appear as tablets. You need to be cautious with everything right now, although we are issuing it for the powder. So it was a time of uncertainty, a time of many unknowns, and we just had to really adapt and move with it over that weekend. So the nitazene that was confirmed is N-porolidino protonitazene. So this is a very new substance to the market. It only entered Europe in 2023. It is now under intensive monitoring by the European Monitoring Centre and their early warning system as of the 11th of December. And this is the main this is the only nitazene that we are seeing. It is occurring in a light sandy brown powder, and we're seeing this in both locations in which we've red alerts issued for. So important for us in terms of our harm reduction and what we need to know, both smoking and injecting carries risk. So some of the powders were being sold as new heroin, which is stronger, and people were being told to smoke. Smoking was still leading to overdoses. Some people were receiving this as heroin and were being told it's just heroin, so they were completely unaware. I think what's really important to note with what's going on in the Irish market at the moment is it's not being mixed with heroin. So the heroin is heroin, but this powder is a completely separate entity that's not being mixed with it. And what we are hearing is there's different colours, it's burning differently. What we can confirm, it's definitely burning to a different texture. So it's burning like a jelly or a kind of a pasty. So this is something that people will notice when they cook it up, and that's important for harm reduction. So we do have I suppose, an ongoing situation. We are monitoring and we're using the emergency call-outs. We are seeing that we will monitor peaks and we're looking at baselines, but we have to decide, and I suppose I minimise the red alert for when it's most needed. So in terms of the Dublin overdose cluster, we've had 57 through that period from the 9th to the 14th. And since the 6th of December, we've had 17 cases in the Cork region. It's the same powder. We think it's possibly linked with the Dublin market, and there has been law enforcement moves and arrests in terms of that situation in Cork. In terms of our national preparation, we've had an uncertain question mark, I suppose, over what direction nitazenes are now going to establish on the Irish market. We're looking closely at other countries. For now, we know it's in a powder form, but we don't know what direction it'll go. So we still have our red alerts in place for the 2 counties, but we're asking all other areas to start preparing while they have time to. So start putting those interim plans in place. We've issued some guidelines. We've established a national red alert group with our labs, our law enforcement, our hospital representatives, and our oversight group. So if we need samples, this group will move quickly to review cases. We are asking services to report overdoses of concerns and drug market changes, anything that's going on at ground level. So we are constantly reviewing that. A memo has been shared with emergency responses, so they are aware of the additional naloxone may be needed. This is a high risk situation, and we're working on a fact sheet for medics in the management and understanding of what may present if there are outbreaks. So for now, our surveillance tool is the emergency call outs as well as the services feeding into us, but we are asking areas to use this time to prepare, to work with people who use drugs, ask them where they want to see the messages, how would you reach them on a weekend if this does kick off in your area, and what do they want, what type of communication and resources do they want. As well as that, we've emergency supply of naloxone in our treatment centre in the city, and there's an expansion of the peer-to-peer naloxone programme, the Circle, which has been rolled out. So just my last slide, because I know we're tight for time, just on risk communications. We do need communities to be prepared, but we also need to minimise the alerts until necessary to minimise overload. So in Ireland at the moment, there has been a fentanyl narrative in the media. Up until very last week, there was also very sensationalist media attention on fentanyl being this deadly substance which could be here, and it's almost taking the benefits away from the red alerts. Some people are saying, oh, nitazenes, but it's not fentanyl. It's almost giving a false reassurance. We need the communications to be taken seriously when they're issued, and I suppose what we do know that the nitazene that's been detected on the Irish market could be 25 times more potent than fentanyl itself, and we know that from in vitro studies in Ghent University very recently. So with our communications, we want to the message to really resonate. So to come from a trusted source, to work with the communities, to work with people who use drugs, that it is reached, so they know who is at risk, where the date and the situations occurring, and importantly, to put those safety plans in place so that harm reduction is taken really seriously when it's needed in terms of buddying up their safety plans, carrying and using naloxone. So it is really important that we work together with the NGOs and people who use drugs. So we are coordinating, we're monitoring what's going on, but that they're used for the trusted communication on ground level. So they know the people that they're working with, they can put the information into their hands, they can give them naloxone, and that's going to be the credible source, and that's what worked really well in the Irish response. So I think I'll finish it on that. I went through a significant amount of information there very fast, and I may have missed some parts. So if there's questions, please do put them in, and I'm happy to answer them throughout and at the end. Thank you so much.
Thanks a lot, Nicki. That's really great. Loads of information. I know you were squashed for time and having to get all that done in 10 minutes. And I noticed there are quite a lot of questions in the Q&A. So please feel free to have a look at those also, and we'll come back to some of them at the end. So for now, just going to move on to our next speaker. So thanks very much. Over to Tony Duffin from the Liffey Drug Project. Thanks, Tony.
Thanks to the SDF for having us on, and thanks to Nicki for her presentation, which there will be complementing information here. So yeah, I'm Tony Duffin. I'm the CEO of the Liffey Drug Project. I want to give you some reflections on the experience, particularly around the cluster of overdoses on the 9th of November onwards. Oh, it's not moving. Sorry, that's better. I'll come back to my little swallow later at the end. So just taking up the point that that Nicki made there around media and foresight. So first of all, just in terms of planning, there is a lot of talk now these days about foresight. There's certainly been plenty of webinars and such around foresight. And back on the 20th of August, there was an article that certainly I was involved with around the poppy ban and destruction of poppy fields in Afghanistan, and indeed there was talk of fentanyl, and Nicki was absolutely right around the point she made around media and trustworthy information. Back at the time in the summer, what we were talking about was something that would fill the gap in terms of the market, the heroin market, and obviously we didn't know what would happen at the time, but we knew that something could happen and something could fill that market. Now, that doesn't mean that there's a direct correlation necessarily between what happens in Ireland or elsewhere with nitazenes, but it may be the case. And I do think that even with the best of intentions, engaging with the media around and being very clear in your messaging, that people can be misquoted, and good news is not good news, and the media often engage in moral panic, and I think that's really unhelpful. But I do think it's important that NGOs and civil society engage with the media. It's just making sure, as best as possible, the information that goes out is credible and doesn't cause moral panic. On the 9th of November, there were on the morning of the 9th of November, an article 10 past 12, 10 to 12 a.m. An article went out. We'd just done our strategic plan launch on the Wednesday, and we had talked about this very subject around not knowing what might happen. Unfortunately, the next morning, this happened, a cluster of overdoses, the beginning of a cluster of overdoses, and the likes of which was unseen in Dublin or Ireland before, and we were talking about what could happen there. So it was actually ongoing or beginning as that was published, and then just in terms of credible and evidence-based information there, I just wanted to highlight that by the 13th of November, the Irish Examiner were putting out what was known by the HSE and our colleagues in the HSE who were working closely with. So look, just wanted to sort of pick up on that whole information piece early on. I'll come back to it in a moment. But for us, and for me, what happened was on the Thursday, the 9th of November, I received a phone call from a GP colleague, Austin O'Carroll. He was at the Granby Centre, a low threshold service, and he was advising me that there were reports of multiple call-outs in the city for overdoses. They were dealing with an overdose at the time, their team, but the fire brigade let them know that they had been out to 7 others already that morning at 8:45 a.m. Very, very unusual for Dublin. They knew they believed that it was involving heroin and that naloxone was working, which obviously is a good indication that opiates are involved. By 12 p.m., reportedly the number of overdoses was now standing at 13. I should say, when at that 8:45 a.m. call, I went straight off to the team and informed the team leaders and such that we needed to get a message out immediately to our colleagues and the people who use our services that there may be a problem, and make them to try and make them as safe as possible with what the information we knew. Then we went on to the 12 p.m. and the number of 13. By 2 p.m., HSE issued their risk communication to people who use heroin regarding the cluster of overdoses in Dublin. That was extremely helpful. The informal had happened, and then we had this formal communication, which legitimizes our concerns as frontline services, not just our Liffey, but other agencies working with people. The informal communication was buzzing, and then you had the risk communication, which is a very serious situation had occurred. By 6 p.m, Professor Eamon Keenan was on the RTE 6-1 News to warn people of the risk to people who use heroin. and he advised that the number of overdoses was by that point over 20. So everyone was working away, getting naloxone out and training people up and getting product into people's hands, which we already did, but we were just ramping it up. By Friday, the 10th of November, the overdoses were still continuing to occur, and we continued to get, as I say, naloxone into people's hands. And we worked in partnership with the HSE and Department of Health to plan for the weekend. So what did that involve? So what we did was, from our perspective, and Liffey, I think it's fair to say that a positive result, if there is any, from COVID was the partnership approach that we had developed in Dublin between the HSE and our colleagues across the board. We had stronger ties, and I think a lot of those relationships kicked in. We had a crisis on our hands, and we had a lot of relationships on the ground. So we got on with it. We put out over the weekend. Team members were willing to go out extra to their usual work. So Cara, Daniela, Leah, and Ian made up two groups of two teams and went out on the Saturday and Sunday. They were, I suppose, they were covering Dublin 1, Dublin 2, the northeast in the city. There were very specific areas where reports of the overdoses were coming in. Prior to going on outreach, staff members contacted several accommodation managers, homeless accommodation managers, to oversee who oversaw 41 hostels, and they were confirming whether there were overdoses on the night of the 10th. Fortunately, there was none on both the Friday and Saturday nights of the weekend in the hostels. Doesn't mean there wasn't any other. There were very firmly other overdoses, but we were particularly focused on the homeless population. During outreach on both those days and throughout the week, staff had the opportunity to interact with many individuals who are actively engaged with or on the periphery of our services. And what that afforded us to do was to inform clients who may be unaware about the presence of nitazene in heroin, provide information regarding how to use it, and the steps employed in the event of an overdose. We were able to gather and pass on information where we were unaware of. We were aware of such information that Nicki has alluded to, the colour upon sale, its texture when burned on foil, where in the city it was suspected to have originated from. And this information came from clients who regularly bought directly from the area or engaged with transactions with street dealers attached around that area. And we were able to engage with individuals who may not possess naloxone and distribute it when necessary. And during the weekend, we had a total of 38 interactions when naloxone was distributed to 27 individuals. Following outreach on each day, staff distributed the HSE's drug warning literature to various hostels on the north and south side for staff to pass on to clients to raise awareness of the ongoing issue with nitazene. Yeah, look, I'm very limited on time, so just wanted to give you some takeaway messages. So informal communication, very, very important. So between pre-hospital emergency care, ambulatory, the fire service, etc., people who were first responders, low threshold frontline services, and others was critical. So that informal communication, that intelligence that is coming up from the ground. Then the formal communication issued early on was crucial in getting as much information as we knew to people who use heroin, but also to assist in mobilising services, giving legitimacy to our concerns. And I thank the HSE for getting that early risk communication out. Partnership works. It was absolutely essential. I've mentioned it around the idea of relationships built up through COVID, and harm reduction works. It has to be said. So my final thought, and this does come back to I suppose Nicki's earlier comments around legitimate messaging and our concerns, but one swallow does not make a spring. A single event does not indicate a trend. And I think that NGOs, civil society organisations and others need to remember that we need, as much as possible, when responding to an overdose cluster, it should be informed by evidence, guided by living experience, people who use drugs, and engage with empathy, because obviously, it is people's experiences, their lived experiences, their living experience, the tragedy of an overdose cannot be forgotten in all the gathering of data. People are frightened and at risk. So yeah, that's my presentation. Thank you. Here we go.
Brilliant, Tony. Thanks so much for that. Some really important messages there, and we'll come back and there's more questions coming into the chat if you want to have a look there as well. Thank you. Just going to move on to our next presenter, who is Lynn Jefferys from the European Network of People Who Use Drugs. Thanks, Lynn.
So hi, thanks very much, everyone. My name is Lynn Jefferys. I am the Operations Manager and the Drug User Organizational Development Project Manager for the European Network of People Who Use Drugs. And I'm going to be speaking to you about the influx of synthetic opiates in Europe from a drug user perspective. So just briefly, EuroNPUD is the drug user rights network covering Europe and its neighboring countries. We are a regional member of the International Network of People Who Use Drugs, and we have an active collaboration with the Eurasian Network of People Who Use Drugs in terms of work in Southeast and Central Europe. So I won't spend too much time talking about what nitazenes are, as my colleagues have gone over that a little bit. And as Tony just mentioned, the situation in Afghanistan is kind of leading us to where we find ourselves now in Europe. So this picture here is showing the opium production from 2019 to 2023. The pink represents the opium production and the green represents the wheat production. And so as you can see, there's a sharp decline from 2022 to 2023. That was a result of the opium poppy fields being burnt. So kind of leads us to this situation we see ourselves in now. In correlation with that, the EU early warning system graph here shows nitazenes starting to pop up around 2019. Increasing in 2020 and 2021 and 2022. We know anecdotally that they were maybe on the scene before 2019, but here they are represented officially in the EMCDDA report. So earlier this year in 2023, the European Monitoring Center for Drugs and Drugs Addiction issued this European drug report. Speaking about now, up until now, the most concern in this area has been focused on fentanyl derivatives, such as carfentanil. However, the appearance of highly potent benzimidazoles or nitazene opiates, including protonitazene, mitonitazene, and isotoniazine has been noted, as well as a detection of opiate mixtures containing new benzodiazepines and tranquilizers. And it's important to note that nitazenes emerged following control measures to reduce the availability of fentanyl derivatives. So we're seeing a direct correlation here between the prohibition of drugs and the emergence of a more toxic drug supply. So that's just an important note to remember. So earlier this summer, I received a text from a colleague that there had been a spike in overdoses in the West Midlands in England. And we were kind of texting back and forth, and EuroNPUD issued this warning, tips to deal with nitazenes and other contaminants in our drug supply, based off the best practice that we have been communicating and we've all been learning about for a while, like not using alone, carrying naloxone, using an overdose prevention center if it's available to you. But an important note on this warning came out of a real life situation where we were telling people to stagger their doses, basically, because 3 people went into a park to use together, and unfortunately all experienced overdose at the same time and were unable to respond to each other. So we added this specific note about staggering doses, using first, and one person using first while the other person kind of kept watch and took care in order to respond if necessary. So we put this out on our Instagram, and it was adopted by other NGOs and civil society networks. And again, that like partnership of communication was really important during the summer. So just in terms of how nitazenes are showing up across different regions of Europe, in Estonia, we are seeing drug overdose deaths increasing. Estonia has experienced a synthetic opiate supply since the beginning of the 21st century, and now we're starting to see these nitazenes. The picture here is a bag of metanitazene that was seized that was causing overdoses. We're also seeing this new mix of known as benzo dope or trank dope, which is a combination of opiates and xylazine, and sometimes benzodiazepines as well. So it's a very worrying combination of substances. And then on the right here, we have a picture of Finland, pills packaged as fake Subutex. So Subutex is an opiate agonist treatment known as Suboxone. It's a type of similar to methadone, some of you might know. So these pills are being sold as, sold and packaged as Subutex, but they actually are containing metanidazine there. So then we have a report from Norway from September and November that a couple batches containing different nitazenes are the cause of overdose deaths, and there's a picture there of how those are presenting. So again, you see that they're tablets stamped with M, and those are containing adenitazine there. That's from November. So just important to mention, I know my colleagues are speaking about Ireland, Dublin, and Scotland today, but I wanted to mention specifically Belfast, Northern Ireland, other places that are experiencing a high level of deaths right now, linked to tablets containing a combination of benzodiazepines and synthetic opiates. The picture on the right there is a tablet that was tested in October that was sold as Valium. It contained metanidazine and bromazolam. So these tablet combinations are causing an increased amount of fatal overdoses. So it's worrying, and we want to keep an eye on that there. So when I was receiving this text over the summer about the overdoses in the West Midlands, I was actually in Canada speaking to drug user colleagues there, and I was in the room with them, and I was saying, look, I just got this correspondence. Like, what would you tell Europe? What would you tell people, to focus on now? And this is the list that they gave me, basically. So heroin-assisted treatment, also known as diacetylmorphine-assisted treatment, so HAT or DAT, and hydromorphone tablets, safe supply interventions. Consumption rooms, including inhalation spaces. Drug checking, peer-to-peer naloxone. I know we've been talking a lot about naloxone. Really important to continue that rollout, and especially in a peer-to-peer mechanism. And then safe supply should be the ultimate goal. So a safe supply of substances for people to use. And an important note about the heroin-assisted treatment and the hydromorphone prescribed interventions is that by the time they intervened in North America, people had really high tolerances from using synthetic opiates. So the synthetic opiates were already so much integrated into the system that the HAT, the heroin-assisted treatment, or the hydromorph wasn't holding people. So people were still having to use on top to avoid being sick. So really important to think about implementing these systems now in order for them to be effective and life-saving. And then just in terms of tools that we have in our belt in terms of drug checking, while not every jurisdiction in Europe allows drug checking, there are organizations such as Energy Control based in Barcelona. And this table here is showing their results over 2023, the different nitazenes that were showing up. Showing they're showing up in different forms. A lot of them are being bought off the internet. A lot of are being sold as Oxycontin, which again refutes this idea that synthetic opiates are a risk only for people who are using street heroin or using street heroin by injection. And as we saw very quickly in North America, synthetic opiates show up in drugs across the spectrum of substance types and cohort of users. My co-panelists and everyone here will be very familiar with Wedanos that we have based in Wales, a service that we have available for Scotland, Wales, England, and Northern Ireland. Their work has been essential to those regions that it serves, as well as providing an idea to neighboring jurisdictions how nitazenes may be presenting in the supply. And of course, we have many other drug checking services across Europe, which you can find out more about on from the Trans-European Drug Identification Project, also known as TEDI. You can check out their website there for a list of different services across Europe. And then in regards to responses and people who use drugs and community-led monitoring, Input, the International Network of People Who Use Drugs, released a best practice recently this year, stating that people who use drugs continue to provide responsive, effective services such as naloxone and drug checking often before these interventions are legal and adopted into funded public health initiatives. So it's important to note, and for my last kind of point I want to make, it's important to note and remember that as we go deeper into this synthetic opiate situation in Europe, that people who use drugs are going to be at the forefront. We're already at the front lines of this battle, and to recognize expertise and amplify their voices and recommendations and initiatives. So thanks very much for having me. And there's my contact information there.
Brilliant, Lynn. Thanks so much. Really important context there to share as well, and recommendations. Thank you. And there's more questions emerging in the Q&A if you want to have a look there too. Thank you. I'm just going to move on now to our last speaker, who is Vicki Craik from Public Health Scotland. Thanks, Vicki. Over to you.
Hi everyone, my name is Vicki. I'm a Public Health Intelligence Advisor on the drugs team at Public Health Scotland. And I help to manage the radar system, and today we're going to talk about the next generation of new psychoactive substances in Scotland. So radar stands for Rapid Action Drug Alerts and Response. It was an early warning system that was set up by Public Health Scotland in 2022, and when we were designing it and developing it, we wanted it to have a few key characteristics. So we wanted it to be trusted because we wanted people to share sometimes quite sensitive and personal information with us. We wanted it to be accessible, and by that we mean that anyone can report their concerns directly to Radar anonymously using our reporting form. Anyone can join our network, and most importantly, anyone can get that information back out. And every 3 months we publish up-to-date data in our reports and our dashboard. And one other non-negotiable characteristic that we had was that it had to be multi-agency. An early warning system is not something that could be managed by one service or organisation, so we had a huge amount of support from many organisations to get us to this stage, and we have a huge number of people that continue to send us their data and reports, and we're very grateful for that. So radar is effectively a surveillance system, and by that we mean it's a system that collects, monitors and assesses data. Some of the data sources that we get in are really good quality, high certainty data, such as our kind of official statistics on drug deaths in Scotland, but there's quite a time delay from the last death occurring to that data being published. So as an early warning system where we wanted to get a hold of the trends before they fully emerged, we had to find other data sources. And what we try to do is try and publish these as often as possible. They might be less certain than our national statistics, but it helps us build a bit of a picture. Another thing that Radar did was it implemented this bottom step in the pyramid. So these are reports from services, people at risk of drug harms, people that are working in hospitals that can report directly to Radar. Low certainty of some of the reports that we get, but they come to us in real time, which allows us to act quite quickly. So what we're going to cover in this presentation is we're going to go through the layers of the pyramid to build that overall picture of surveillance. Just be mindful as I go throughout these slides, I will be talking about some data on deaths. And my thoughts are with everybody who's impacted by drug harms. So if we start at the bottom with that real-time data that we're collecting from people at risk and people that are working in our services, we can start to identify patterns. Sometimes one report by itself doesn't tell us the whole picture, but when we're getting similar reports from across the country, it allows us to identify what our priorities should be. What we've seen is we've had 150 reports since we set up Radar in summer 2022, and each quarter, the majority of the reports either concern the street benzo supply having adverse effects, or changing use of cocaine, introduction of crack cocaine, cocaine injecting. What we've seen since January 2023, though, is we've had more concerns reported to us about the heroin supply. So mirroring some of the reports that we had in Ireland, that the heroin is lighter in colour or darker in colour, it's burning differently, it's leaving residue, people taking their usual dose and ended up in hospital. And what we see for data for October to December that's not been published yet is that the majority of concerns we have are again around this heroin supply. So we take that data and then we combine it with other statistics on drug harms in Scotland. So we collect data from a range of different services. This chart shows ambulance administration incidents by the Scottish Ambulance Service, drug-related attendances to the emergency department, and suspected drug deaths in Scotland as recorded by officers at Police Scotland. And this allows us, again, to see almost in real time how our trends are doing and what direction things are going in. We can see that in 2021, pretty much drug harms were at an all-time high. We had record levels of drug death. That did come down in 2022, and we had a 20% reduction in drug deaths. But what we've seen since January 2023 is, unfortunately, the trend is reversed again, and we've seen an ongoing increasing trend. And our concern is that because of the emergence of these new drugs, that trend will continue. That data is available on our dashboard. And for those of you in Scotland, if you want to see what it looks like in your specific health board area, you can filter the data on our dashboard. So we've got our data from services and people at risk. We've got our data from our harm indicators, and we also combine that with our toxicology data. So our three main sources are postmortem toxicology, prison drug analysis, and hospital toxicology at the Queen Elizabeth University Hospital in Glasgow. And without this data, an early warning system just wouldn't function because we have so many drugs in circulation at the minute. Just in the last couple of years in Scotland, these drugs toxicology services have identified about 15 new drugs for the first time. There's a lot of drugs on this list, but there's a few that we're particularly concerned about. I think my biggest concern is probably bromazolam, which is a new benzodiazepine. Obviously, the emergence of these new synthetic opioids, these nitazenes, and one that's on our watch list for 2024 is increasing detections of xylazine. So the toxicology data really gives us a kind of wealth of information about drug taking in Scotland. So if we look at this Glasgow Hospital Emergency Department study, they tested leftover serum samples from patients that have attended an emergency department due to acute drug toxicity. Data for the last quarter, which goes up to August 2023, shows that they analysed 157 samples. And out of the 157 samples, they made 810 different detections of illicit drugs. There was 52 different types of drugs that they detected, and the average patient had 5 different drugs, once metabolites and any medicines that they were prescribed or medically administered were removed from that count. The ASSIST study has given us a wealth of information. A few of the kind of key points, though, is the sheer scale of the benzodiazepine problem that we have in Scotland. In this 12-week period between May and August, 30 different types of benzodiazepines were detected. And the data on the right, which shows a whole year of data, shows that benzodiazepines were the most commonly detected type of substance. What we also see, though, is the most common individual drug in samples is cocaine, and that's been quite consistent across all the quarters. And I think it's important to highlight the risks of cocaine. Sometimes cocaine is not seen as being as harmful, as problematic as some of these depressant drugs, but it is in the majority of these hospital admission samples. What we're also seeing in our toxicology is a real shift in the benzodiazepine market. So this data here is from postmortem toxicology in Scotland. And for cases that tested positive for a controlled drug, nitazenes was present in an average of about 50% of cases in Q2 of 2021. But by Q2 of 2022, that had dropped to around 20%. So for being 50% of samples to 20%, that's a huge decline in quite a short space of time. What we've seen, though, is people haven't just stopped taking benzodiazepines. The benzodiazepines that they're taking has changed. And now our street benzo supply is dominated by the use of bromazolam, mainly found in white or blue or yellow pills, but increasingly we're seeing bromazolam powder being detected. And this has concerns because the reports that we're getting from people that are taking these drugs is that they're very heavily sedating. They're leading to loss of consciousness, blackouts, and respiratory depression. So we're seeing lots of cocaine, we're seeing lots of benzos, but we're also seeing an increasing number of nitazenes being detected in Scotland. So the first detection that we have recorded of a nitazene in Scotland was in mid-2021. The areas in which we've had the most number of detections is Glasgow, Aberdeen and Edinburgh. And we can't really be more specific than that because this is something that has affected the whole country. I would say that most areas of Scotland have had a confirmed detection of a nitazene, and the areas that haven't had a confirmed detection of a nitazene, it's not because the nitazenes aren't in the drug supply, it's just because we're not testing for it in that area. There's 4 main nitazenes that we are testing for. The most common one we find is meat-nitazene. You'll notice that in the situation in Ireland, the main nitazene implicated was N-pyrrolidinoproteinitazene, which is slightly different than this N-pyrrolidino-E-nitazene that we have. So what we're likely to see in Scotland is our detections are probably underestimated due to the fact that we're testing 4 of the family of substances. We put an alert out for this in January, and at that time, almost all our detections were in drugs that were missold as oxycodone. But as the year has went on, we're seeing more detections in our benzo supply and more detections in our heroin supply. And normally they are mixed with other drugs. So in that sample there, heroin was detected alongside nitazenes and a whole host of other substances. The number of nitazenes that we are detecting in deaths has also increased. So this is post-mortem toxicology data for the whole of Scotland. We started frequently testing for nitazenes at the end of 2022. So until then, we had a very low number of deaths, but in recent months, we've seen quite a significant increase. Still low numbers overall in comparison to detections of other drugs, but we're concerned that this rate of increase will continue. Since the first detection in Q1 of 2022 to the end of September 2023, they have been detected in 25 deaths in Scotland and again across the country. They've been detected in 25 deaths, but they've actually had 35 detections, and that's because in 10 of our deaths, the nitazenes had been detected in combination with each other. So rather than just getting one nitazene, you're seeing, for example, meat-nitazene and protonitazene mixed together. We're thinking that this is actually coming from the source, so whoever's making these drugs at source is selling it as heroin, but it contains meat-nitazene and protonitazene mixed together, which makes polydrug use unavoidable. We've never had a detection in post-mortem toxicology where there's not been another drug detected alongside it, normally quite a few other drugs, and there's always a downer drug in the mix there. We've not been able to identify a clear pattern, which makes us think that this is quite widespread, but it is commonly found alongside heroin, cocaine, codeine, and bromazolam. In this data here, although these nitazenes were detected in the deaths, we can't fully ascertain just now what their contribution to the deaths was. So all that information is available on our website. If you're wanting more, you can check our information, alerts and reports at publichealthscotland.scot/radar. Thanks.
Brilliant, Vicky. Thanks so much. And thanks very much for getting that up-to-date information for today's webinar as well. Just invite all the other panellists and my colleague Austin to join us. Thanks so much to everybody also for firing through as many questions as possible that were coming in the Q&A. There's quite a few. One that I just wanted to pick up on, because quite a few people were asking the question, was in terms of the naloxone response, and there seemed to be a little bit of confusion around that. And certainly what we know from other countries is that it's not necessarily the concentration of naloxone that needs to be higher, it's that what they find is that people often require repeated doses of naloxone in terms of what you would usually expect from a heroin-related overdose that we would be more regularly seeing. So it is important to have more naloxone available. I noticed that Lynn posted there in one of the answers to the questions that ideally carrying a couple of kits. We use in Scotland, it's the Pranoxad and Nixoid are the two main products that we use. So we are encouraging people to carry more naloxone on them and expect that you may have to use additional doses should an overdose with synthetic opioids occur. Austin.
Yeah, thanks, Kirsten. Just to be clear on that, because there's been a few questions that suggest that out there there's some confusion. It is about more naloxone, but administering it as previously advised and taking the same gaps between doses. It's just that the person may need more doses. So these messages are confusing. I don't want there to be more confusion. So I think the first question is for Vicki to clarify. In Dublin, we seem to have some picture of what substances might be involved in really high quality information from people that have used those substances, describing what they physically look like, how they cook, or whatever. Do we have any data like that in Scotland, or could we carry that across from Dublin and presuming that it's the same here?
I suppose what we've not seen in Scotland is, I suppose, an incident on this scale where the information resources relate to each other. What we get with the reports to Radar is very similar reports, but not specific to one individual incident. So we might get reports from one area that says that the heroin was black and it didn't dissolve properly, and then we get similar reports from another area. So the picture's not quite clear because I think it's a bit more widespread. Whereas the information that Nicki's got, because it was kind of clustered together, I think it's a bit more specific.
And yeah, there was some differences obviously in what was reported from Nicki there as well, especially in terms of it being a slightly different picture in that it was nitazene only that you were detecting. It wasn't nitazene in the heroin or in benzos or other drugs in this. So there was some questions around that as well. Austin.
Yeah, and the other question is my own personal interest, so maybe that's why I prioritise it, but it's about how to get messages out to people at risk. So obviously we're doing some of that in Scotland, but is there lessons from Dublin? Is there anything or from wider across Europe?
Yeah, or from Europe. Tony, did you want to go first?
Yeah. So to people at risk, I think it's relational quite often. It's this frontline services. It's people who use drugs, actively use drugs, getting those. I don't think I'm teaching anybody anything new, but it is really important to note that the clear messaging, the messaging that we got from the HSC, which was approved by the HSC, but also very strong harm reduction messaging going out, handing it to people. It's all about who is the message designed for. There's the wider communication. The HSC were putting up uniquely on that weekend boards, the lit up boards advising people of the danger, because obviously you're reaching a wider group of people as well. That was great. And obviously engaging with the media, but that's another group of perhaps people who use drugs that we aren't engaged with. So there's the different levels and the different ways of communicating and getting your message across through mass communication and also relational. I mentioned that in the presentation. Don't underestimate the informal and the formal communications. You've got to do both, and you've got to do it really widely, especially during a cluster like that. And look, I'm not involved with the information being provided in Cork, but it's very, very similar. Smaller city in Ireland, working with the national office, as far as I understand, getting the information out nationally and locally. Yeah, really good stuff. Yeah.
Thanks, Tony.
Nicki, want to add anything?
I think the information sharing, sorry, Lynn, come in a second. What I was just going to say before I came to you was, I think the information is key in getting that out, but I would love to see it accompanied with action, like drug check-in services. So here's all the information that you need that can help you stay safer, but also here's drug check-in services, here's drug testing strips, and Lynn will come to you first, and then Nicki, maybe just to ask you also in terms of the drug check-in strips and what you're doing to look at that for Dublin or for Ireland in general. Lynn, thanks.
Yeah, just to add to what Tony was saying, I think partnership is really important, and it's about getting the information and then disseminating it. So like what Nicki was saying, getting the alerts or the information from the 999 calls, like once in the morning and once in the evening. Maybe Tony was saying that. So getting the kind of reports of the overdose incidences, and then how we feed that back to people who are working with people who use drugs, service providers, people working in hostels, and then also people who are using the drugs themselves. Not from a European example, but from my time working in Canada. Again, this is like a local jurisdiction, but in Vancouver, we had a bad dope text alert. So it was just a text phone number that you could sign up to. And if there was a presence of a pink pebbles containing fentanyl. The text alert still exists today. A text would go out and you would get it on a phone, very accessible for people, even if you don't have a smartphone. Again, this is in the context of multiple overdoses and a really high amount. But I think it's something that we should look at across Europe and in different jurisdictions, because it does give a bit of a local communication, very low barrier communication style mechanism.
Thanks, Lynn. Nicki?
Yeah, just following in on what Lynn and Tony were saying, just first on the communication and then on the drug checking. People got very focused on the numbers of they were non-fatal overdoses, and obviously we were using the surveillance tool, but we appreciate that that's not all of the overdoses because there's peers and there's different settings. So we had to pick one tool and we used it. People got very caught on what's the next number, what's happening. Really what we should have been focusing on was it's out there, let's go, let's move the response, getting that information out. So that sometimes I think people can get very caught on they want to quantify what's happening and give a kind of a piece there. In terms of the drug checking, I know there were some questions in on what labs we used and how we used it. So we don't have a formal early warning or drug monitoring system. We don't have a routine drug checking service like the Netherlands or another country. We had established relationships with labs who begin using different methods for back of house analysis, and then partnership with law enforcement actually was quite significant for our responses. So we'd the treatment centre lab, the HC treatment centre lab, who do syringe analysis and routine urine analysis, so that's LCMS. We the state lab who look at drug related deaths. They were able to look at the bloods through GCMS. We had the forensic science lab who were the guard, the police lab, and we also partnered with Trinity College who had NMR. So we were looking at different samples throughout the day in the absence of drug checking, but we were able to obtain samples from the police and from services, and people were generally afraid. So people were contributing something at that point. But to also note, the syringe analysis project was really useful in terms of used syringes from overdose cases. So in the absence of drug checking, that was something that we quickly adapted. And I think the law enforcement, they really played a great role in a health-led response here in terms of how they worked. So credit is due there too. In terms of the testing strips, there is kits being developed specifically for nitazenes. So I think our message is that, the fentanyl test strips aren't going to work. We don't have fentanyl in circulation. That could give a false sense of security. So our lab are working with law enforcement to obtain samples, to conduct some tests on the strips to see how they work, and then we'll kind of make a decision there. So that's where we're kind of at with it. But I suppose in the interim, and while we don't have something to offer, it's the services and everyone that could get samples to us or use syringes, which are really key. And I think the value of drug paraphernalia after an overdose and using that to get something is also really helpful. And in terms of the powder, all of the samples we have had, I know there was questions about radar obtaining information, us having it, they came from services on the law enforcement. So that's how we had an image. But we are conscious that it could change. So we don't really want to put too much attention on the powder because something could change very quickly and people won't be as aware. So it's a difficult one in terms of risk communications, giving one drug and giving a kind of a sense of security there. So yeah, thanks.
Thanks, Nicki. It's really helpful. I'm conscious of the time. Vicki, is there anything you'd like to add to what's just been said? And then we will, I'm afraid, have to finish. I think we could have been here for 3 more hours.
No, well, I suppose if we're to end on a point, it'd be to plug Radar. If you're seeing anything of concern, report it to us. Check out our alert and the resources that SDF have done. Spread the word before the holidays and stay safe. Thanks.
Thanks, Vicki. So just a massive thank you to all the panellists, to the SDF communications team behind the scenes for supporting this webinar. Really grateful to have everybody's input today, and especially all the questions from people who've joined as well. And I'm sorry that we didn't manage to get through all of them, and it just highlights the real sort of concern and interest in this subject, and certainly something that we'll come back to in the new year. So yeah, just a thanks again, and wishing you all a very happy festive period, but to also really take care and look out for each other, and we'll see you again in 2024. Thanks very much.